Okay, good. I'll start. Hello, everyone. Assalamu alaikum. I am Fiza Gilani, Chair of the APPNA-MERIT HIV Committee. Welcome to the 6th webinar of the HIV Awareness, Prevention and Education Project in Pakistan, jointly designed and led by APPNA-MERIT HIV Committee in partnership with Government of Pakistan and with the Common Management Unit, HIV, TB and Malaria, Government of Pakistan, and the Medical Microbiology and Infectious Diseases Society of Pakistan. This is the last webinar of our weekly series, but after this we will continue monthly series. We'll have one webinar per month for next few months. So our moderator today is Dr. Safana Mushtaq. Dr. Safana Mushtaq graduated from Quaid-e-Azam Medical College, Pakistan. She completed her residency in family medicine from Indiana University. Sorry, guys. She is currently working in New Hampshire in family medicine program. So now I am having technical issues today.
It's going well, Fiza. We can hear and see you.
Yeah, okay. So her passion is in family medicine and preventive medicine, and she does lots of volunteer work for prevention. And her another passion is psychological issues in HIV, women, and depression. And she is currently a board member of APPNA, and APPNA is a local chapter of APPNA, which is New England chapter of APPNA. So here you go, Dr. Mushtaq.
Thank you so much, Dr. Fiza. Assalamu alaikum and hello, everybody. I would like to welcome all our speakers, Dr. Fiza, and all our attendees. So as Dr. Fiza mentioned, this is our 6th webinar of APPNA-MERIT HIV series. And today our topic is caring for pregnant women with HIV disease and preventing HIV transmissions. So first of all, I would like to welcome our speakers. So we have Professor Dr. Susan Cu-Uvin, Dr. Fatma Mir, and Dr. Aisha Ilyas. So before I introduce our speakers, I just would like to take a couple minutes or maybe less for our housekeeping. So I want to mention everybody will be getting evaluation forms. So kindly do fill out evaluation forms and they will be emailed after our webinar session. So the other thing is change of schedule of the webinar, like Dr. Fiza mentioned. So we're moving from weekly sessions to monthly. So there's not going to be any session next Sunday, and schedule will be put out for monthly session. And we have about 4 more to go. And the other housekeeping item is please post your questions in Q&A box. We would like, chat box to be used for comments. All right, so excited to have everybody. I would like to introduce our first speaker, Professor Dr. Susan Cu-Uvin. So Dr. Susan Cu-Uvin, she's a professor of obstetrics and gynecology and medicine at the Alfred School of Medicine, Brown University, and professor of health services, policy, and practice at School of Public Health. She's the director of the Brown Global Health Initiative. She was the principal investigator of the Brown Tufts AIDS International Training Research Program, which ran for 20 years. She was the director of the Immunology Center at the Miriam Hospital from 1999 to 2009. She has been the principal investigator and co-investigator on many NIH and CDC grants since 1996. She remains one of the most prominent co-investigators in HIV and cervical cancer, microbicide studies, and mucosal immunity in the female genital tract, leading RO3, U54, and U19 grants. She served on the Institute of Medicine's Committee on Perinatal Transmission of HIV and committees on women, health research, and HIV testing and access to care. She's a member of 3 DHHS guidelines panel, which are Perinatal Antiretroviral Guidelines Working Group, the Adult and Adolescent Treatment Panel, and she also chairs the HPV Working Group of the Guidelines for the Prevention and Treatment of Opportunistic Infections Panel. She has been a member of several NIH review committees and NIH Advisory Committee on HIV-related research in women and girls. Dr. Cu-Uvin works as a structured mentor for junior investigators at the Brown, Harvard, Emory, and George Washington universities. She's the director of the Providence and Boston Center for AIDS Research and NIH Designated Center, and is just one of the 2 women CFAR directors nationally. So without further ado, Dr. Susan Cu-Uvin, please go ahead.
Thank you so much for a very generous introduction. Welcome to everybody. First of all, I want to thank the organizers of this webinar for inviting me to give the talk this morning. And I would like to welcome all our distinguished panelists, other speakers, and also all the audience that are joining us this morning. I will share my slides, and I think I will stop my video just to make sure that we don't have technical issues, because the videos take quite a bit of bandwidth. So, and can you see my, oh no, hold on. Can you see my, where's my slide now? I thought I shared it. Share screen. I am so sorry. I thought we practiced it and we had it.
I think you had to keep your video on to show the slides.
Here. I did Fisa, right? I got clear.
Yeah, in Pakistan is right here.
Yeah, so that's the last icon, Dr. Susan.
I can't find it on my screen.
If you look on the on your first row, the last one, just the upper row, next to SRO DAO only.
Are you using 2 screens, Susan? Yeah, I think you got it.
Yep, yep.
I don't.
Perfect.
You know, I don't see it myself, so that's the problem, but you can see it, right?
Yes, we can see it.
No, there are no slides yet. It's your Gmail account. It's your
okay.
Google.
Well, no, it shouldn't be there. Let me stop the share. Let me share it again, because I know that we practiced it and it was up there. And now.
So meanwhile, I will say there is a question in the chat box that if we get the e-certificates, yes, you will get e-certificates, but you have to fill out the evaluations. And my second request is please fill it out, even if you don't need the attendance certificate. And please fill it out. And we are creating the HIV course out of these webinars. Then we will provide the CME from that course. Thank you.
Lisa, can you see my slides now?
Not yet.
What? I just shared it again.
Walid, can you help?
Yes, please share the screen again, please. We cannot see.
I shared it again, and it should be.
Susan, you want to come out of your Google account? Just close that Google account which we saw on the screen first.
Click on share screen option.
While Dr. Susan is setting up, I see Dr. Aisha Elias has also joined. Welcome, Dr. Aisha.
Thank you so much.
Pleasure to have you.
Pleasure's on mine.
Yes, we see the slides, Susan. Yes, all set.
There, can you see it?
Yes.
Yes.
Okay. Sorry about that technical difficulty. We did practice before, but we're going to talk about caring for pregnant women living with HIV and the prevention for future transmissions. And I think I would just like, why is it not advancing? It's okay. So I think I'd just like to go over a little pathogenesis and background that, as you know, even without any antiretroviral therapy, not all mothers with HIV transmit to their infants. Without antiretroviral therapy, only about 20 to 25% of infants are infected with HIV. This is a big mystery. There are many theories about why, but I don't think we have a definitive answer for why most of the babies do not get infected, even if their mothers have HIV. If a mother is not on antiretroviral therapy and she is going to infect her baby, much of the transmission is not in early pregnancy, but during labor and delivery. And that is why even if a mother comes in labor, early labor, and has not had any HIV medications, we have a chance to intervene for vertical transmission because most of it is after labor, is during labor and delivery. However, if you are dealing with a breastfeeding population, you can see that breastfeeding after delivering a baby gives you 35 to 40% risk transmission. The longer you breastfeed without antiretroviral therapy, the more likely you are going to transmit to your baby. So there was an early discussion, how do we prevent this? And I think universal testing of all pregnant women for HIV is the only way that we really can determine if a pregnant woman has HIV so we can intervene early. In most of the United States or all of the United States, there's universal testing for HIV for pregnant women. Regardless of risk factors, we don't look at risk factors anymore. It takes away the stigma of why somebody's being chosen for HIV testing and others are not. It's part of the standard of care. So you don't have to explain to your pregnant patient why you're doing an HIV testing. You just say all pregnant women are being tested for HIV. The caveat there is if you test somebody early, it doesn't mean that they cannot get HIV during pregnancy. Actually, the studies show that if somebody is infected, somebody is exposed to HIV during pregnancy, the chances of getting HIV is much higher during pregnancy compared to when you are not pregnant. So, since breastfeeding is the cornerstone for infant survival in many resource-limited countries, and it is associated with high rates of HIV transmission, the development of interventions to allow for safe breastfeeding is critical. And the answer to that is combination antiretroviral therapy. Combination antiretroviral therapy, we're very lucky that we have it, although resources are different between different global countries, should be given to mothers, and it effectively reduces mother-to-child transmission. If you diagnose a pregnant woman to have HIV, regardless of the CD4 count, regardless of the plasma viral load, start them on antiretroviral therapy the earliest that you can. Adherence, of course, is very important. And as you know, there is no cure for HIV. So treatment for HIV is lifetime. Even after pregnancy, particularly if the mother is going to breastfeed, adherence to combination antiretroviral therapy is very important. But treatment for HIV is lifetime. We have no cure, we have no therapeutic vaccines. So as of the moment, once you start a patient on antiretroviral therapy, they should continue taking it for life until we find better treatment or cure or therapeutic vaccines. The WHO recommends exclusive breastfeeding up to 6 months of age, with continued breastfeeding along with appropriate complementary foods for up to 2 years or longer. Mothers should be encouraged to breastfeed their children for at least 1 year. The reason for exclusive breastfeeding is that it has been found out, much of the studies were done in Africa, that mixed feeding, which is, formula feeding, breastfeeding, supplemental feeding, early in infant's life, leads to an increased risk of HIV acquisition. So if you have the mother on antiretroviral therapy and she's adherent to it, the amount of virus in her blood and breast milk is low, she can safely breastfeed. But the first 6 months should be exclusive breastfeeding. And you know that in resource limited countries, the best nutrition for the baby is breast milk. Without breast milk, many babies become malnourished or die of diarrheal diseases. So in the US, we do not recommend breastfeeding. In many Western resource-rich countries, we do not recommend breastfeeding, although we are becoming more liberal with that, because many mothers want bonding with their baby, and we recognize that breast milk, even from an HIV-infected healthy mother, is the best nutrition for their babies. What has changed? It's been 50 years since we have been dealing with the HIV epidemic, and we have no cure, we have no vaccine, but we have had the biggest progress in preventing mother-to-child transmission. In the early part of 1993, no antiretroviral therapy was given, and we said 25% of the babies got HIV. Then we had monotherapy with ACT or zidovudine alone. And even with monotherapy, look at the marked decrease in perinatal transmission of HIV. Then came the era of combination antiretroviral therapy. And much of the resource-rich countries have less than 1% mother-to-child transmission if the mothers are on combination antiretroviral therapy. To be honest, in the US, there were less than 60 babies that were HIV infected last year. And that is mainly because the mothers had no prenatal care. The mothers were diagnosed very late to have HIV. The mothers were non-adherent to therapy. But if mothers are adherent to therapy, even within our own clinics, I don't think we have seen a perinatal transmission if the mother was diagnosed and adherent to therapy in the last 15 years. So in the US, we have very few perinatally infected babies, but that is not the same for the rest of the world. The good news too is if you look at the WHO report for the coverage of combination antiretroviral therapy to prevent mother-to-child transmission, in the last 10 years, there has been a very high increase, almost reaching 90% of coverage. Now, that is not to say the same all over the world, but this is a wonderful news because if we can give 90% of pregnant women antiretroviral therapy, we can really try to end mother-to-child transmission. The coverage of antiretroviral therapy to prevent mother-to-child transmission, unfortunately, varies from region to region. And in Asia, you can see we're only above 50%. The Caribbean is doing very well. East and Southern Africa is almost 98%. Eastern Europe and Central Asia have no reports, and we are very worried about HIV incidence and HIV mother-to-child transmission in these areas. Latin America is better than Asia. Middle East is the least, I think, in North Africa in terms of reporting. West and Central Africa is almost the same as Asia. And of course, in Western Europe and North America, it's almost 98. I mean, at least in Rhode Island, we reach 99% for coverage. And what does this mean? There are a lot of gains in preventing mother-to-child transmission. From 2010, if you look at Eastern and Southern Africa, which is almost over 90% of giving antiretroviral therapy to pregnant women, the transmission rate over the past 10 years have come down almost halfway. And the same for Western and Central Africa, not as much as East Africa, but you can see the trend over the years that the more you give antiretroviral therapy to pregnant women, the equivalent is decreasing vertical transmission. Now, there is a cascade, of course. You have to know how many women giving birth are HIV infected. So, universal testing for HIV among all pregnant women is the beginning of the cascade. Because if we don't know that they have HIV, we certainly cannot even identify that they are at risk for their own health as well as for perinatal transmission. If we are able to identify women who are HIV infected, then we can offer them antiretroviral therapy. But you can see that the coverage and the cascade of care becomes smaller and smaller and smaller. So antiretroviral coverage can be up to 58%, but early infant diagnosis, which is also very important, falls down to 33%. And transmission rate brings it down to 20%, but not absolutely to a lower rate. Because we need to test, make sure that we identify all the women, make sure that the acceptance of antiretroviral therapy is high, adherence is high. We need to do early infant diagnosis so that those who need longer prophylactic medication to prevent postnatal infection, as well as to treat the infants who are HIV infected, both with Bactrim and antiretroviral therapy is done early, and we can really bring down new child HIV transmissions. Where is the cause of vertical transmission? If a mother is not breastfeeding, so this column, and these are studies from Africa, unfortunately. If a mother infected during pregnancy is the red bar, and that is hard to prevent because if you only test the woman once during pregnancy, you're not able to know whether they were infected during pregnancy. The bigger chunk of the problem is mothers did not receive antiretroviral therapy, which is your orange bars here. And then mothers lost to follow up. Mothers started antiretroviral therapy very late, and the child has been infected. Among the breastfeeding population of mothers, which is this lower bar here, most mothers infected during breastfeeding again, and we don't know if we don't test for it during breastfeeding, so they can infect their babies. A lot of mothers did not receive antiretroviral therapy, which is your orange bar here, and so they breastfed their babies without any antiretroviral therapy. And then mothers stopping antiretroviral therapy or lost to follow-up. So if you look at the cascade, we have the science, we have the antiretrovirals, but implementation of all these guidelines is going to be the Achilles heel of bringing mother-to-child transmission to almost zero, because you have to fulfill all of these steps along the way. And it can happen probably in academic medical centers, but in countries like Pakistan, Bangladesh, some parts of Africa, most of the deliveries happen outside of the hospital system, many of them in rural areas that do not have the means of all these things that we want to happen to decrease mother-to-child transmission. So we can write the ministry guidelines in the best way possible, but they remain guidelines in paper, and we really need to adapt them to the situations that are more important in your own districts, countries, and your own populations. So we can do all the studies that we want, but at this point, what we call implementation science and bringing down from bench basic clinical trials to the community now is our biggest task, because we know what to do, we know what to give, but how to give it to the population that needs it will vary from one country to another, and even within a country will vary from academic medical centers, urban centers, to rural centers, to indigenous populations, to refugee populations, to at-risk populations that are marginalized. So how does antiretroviral therapy decrease mother-to-child transmission? There is no miracle there. Lowering maternal blood and genital tract viral load is the key. You have heard about U equals U in the United States. When patients maintain below detectable plasma viral load, there almost is zero risk of giving HIV to their sexual partners as well as to their babies. This is what we call U equals U. Undetectable equals untransmittable. This is a very hard concept for us to grasp, but it gives hope to patients who have HIV where there is no cure, and for them to be adherent to lifetime antiretroviral therapy, a massive incentive to be adherent to therapy because they can have condom-less sex. with their partners without giving HIV to their partners if they take their HIV medications and it's effective. And for men and women, it gives a huge incentive for the couple to try getting pregnant by protecting their own health and knowing that they're not going to transmit HIV to their partners and to their babies. So this has changed the whole paradigm of why a person would be adherent to therapy. It used to be only for your own good, for your own health. But now it's for the health of your partners. It's for a quality of life where if your partner doesn't want to use condoms, it's okay if you have undetectable sustained plasma viral load. And for mothers in countries where culturally mothers need to have women need to get pregnant to be considered as part of a society and not as failures because they cannot have babies. This is a huge incentive. Take your medication. You are not going to infect your baby. We actually say effectively zero transmission in our guidelines. And that is, putting out your neck as long as patients are adherent to therapy. And of course, you give pre-exposure prophylaxis to the infant through transplacental passage of antiretroviral medications and post-exposure to the infant, because if you give breastfeeding, breast milk contains antiretroviral therapy. Some mothers will want to give medications to their babies while they are breastfeeding. So, what can we give? Dolutegravir, which is now generic, is the first-line regimen in combination with nucleoside reverse transcriptase inhibitors as the backbone. And efavirenz at a low dose is an alternative, and raltegravir is also an alternative. But for much of the world, dolutegravir, which is an integrase strand inhibitor, is affordable and is now generic, is the cornerstone of treatment. Now, for pregnant women, there was a big controversy in terms of dolutegravir. Because when we give medications to the mothers, remember we have two patients, the mother and the baby. And we have concerns about the drugs that we are giving to the mothers. Will it cause prematurity or low birth weight in the babies? Some protease inhibitors have shown prematurity and low birth weight. Not all the studies are in consensus, but there is a signal that protease inhibitors might be related to prematurity. Congenital anomalies. Remember, efavirenz we couldn't use because of neural tube defects until more studies were done, and efavirenz was not related to neural tube defects, and efavirenz became the first line of therapy. Dolutegravir has also been marked with controversy for neural tube defects, but we will talk about that later and why it became the first line therapy despite the early signals that it can cause neural congenital anomalies. We have problems with tenofovir because it can cause fetal abnormal bone mineralization and might affect growth. With the longer use of tenofovir, we have found that this is only at the initial part of treatment and it stabilizes and it really is not progressive. So tenofovir is now one of the recommended treatments. You can have hematologic abnormalities. You can have some mitochondrial dysfunction. We don't know the long-term effects of these drugs that you give to a mother, either with an HIV-infected baby or an HIV-exposed but uninfected baby. But, you know, in my clinic, I now have the second generation of perinatally infected children who are giving birth to their own babies, and they are doing very, very well. They don't have malignancies, they don't have cardiovascular long-term effects, and they never had neurodevelopmental problems. So I think the longer we follow these cohorts of perinatally exposed or perinatally infected babies who went on early antiretroviral therapy, the more we are convinced that giving antiretroviral therapy, the benefits outweigh the risk of any problems that we are going to face in the future. So Dolutegravir. Remember that efavirenz used to be the first-line treatment, and then came Dolutegravir, which is a better antiretroviral medication compared to efavirenz. It has better efficacy in terms of bringing the viral load to below detectable compared to efavirenz. The resistance profile is much, much better than efavirenz, which just needs a single mutation to develop resistance. Tolerability of Dolutegravir is so much better than efavirenz that has a lot of central nervous system side effects from nightmares, dizziness, depression, fogginess, unclear thinking, not able to concentrate, and sometimes rare suicidal events from depression. So in terms of a choice, if it is safe for the mother and the baby, Dolutegravir wins over efavirenz in all aspects. That's why it was very important to study Dolutegravir and its safety for the mother and for the baby, because efavirenz was not perfect. It was cheap, it was generic, but it was not perfect, and we should be doing better for pregnant women. What was the issue? The Chapamus study was done in Africa. And at the early part of the Chapamus study, there was a signal for higher neural tube defects in women that were exposed to Dolutegravir before pregnancy and who took it during the early part of pregnancy. Over time, it decreased from 0.9 to 0.3, but compared to all the other regimens that are efavirenz-based or no therapy at all, or compared to the protease inhibitor, this is still high. So 0.9, you follow them up to 0.3, but still higher. So we said Dolutegravir should not be used in women who are attempting pregnancy, who are in early part of pregnancy, which is the first trimester. However, they followed up this cohort longer and longer. And as you can see, from 0.9 to 0.3, it's now 0.19. So it's almost becoming the same as all other regimens. And that is why Dolutegravir is now considered the preferred treatment for women, even if they're trying to get pregnant or even during the first trimester of pregnancy. So the WHO came out, Dolutegravir-based regimen is recommended as the preferred first-line treatment for people living with HIV, initiating heart, changing if they don't have any resistance to Dolutegravir-based regimen. Women and adolescent girls of childbearing potential, very low evidence of neural tube defects. So we are giving Dolutegravir. Infants and children have also been approved to take Dolutegravir. So, as I said again, the older regimen we were giving was efavirenz with Truvada. The newer regimen now is Dolutegravir with Truvada or generic tenofovir, emtricitabine, generic Dolutegravir, which is cheap and affordable for many of low resource income countries because of the generic resources for these medications. Talking about COVID. COVID is a pandemic and it has affected all countries in the world, whether rich or low resource countries. This is a pandemic that did not choose who got to be infected. And I think in many ways, many of the North American countries, America reached over 600,000 deaths from COVID pandemic. India, over 500,000, I think 300,000 deaths. Brazil, over 500,000 deaths. Germany, France, UK. It did not choose whether you're rich or poor country. And it was very hard to deal with, even with resource-rich countries. So you can just imagine as it hits the low-resource countries. What was the effect on HIV care? A lot. Even us, we had to go to telemedicine. Even just for a few months, we immediately went back to in-person, but we lost, continuity of care. We lost the ability to keep closer monitoring of laboratory. Some of the patients didn't come to pick up their medications. And in terms of prenatal care, you will see that compared to January, this is the dark blue lines and the light lines, to the month of the COVID, subsequent months versus January, you can see that there has been almost a universal decrease in the number of pregnant women tested for HIV for antenatal care during the COVID era. So COVID has not been good for any kind of care, but also in particular for HIV care, including pregnant women. So the takeaway messages is being on suppressed antiretroviral regimen when becoming pregnant provides efficacy in reducing mother-to-child transmission. There may be some associated increase in preterm deliveries with older antiretrovirals. We can eliminate HIV transmission from mothers to infants. We have the science. We just need to have the will and the resources and how to implement it. When considering drug use in women of childbearing potential, you need to consider the potential for the pregnant women, for preconception exposure, and for the baby. There are limited data in pregnancy, particularly in early pregnancy for newer medications. But in terms of Dolutegravir, efavirenz, which are the primary and alternative, we shouldn't have any problems with this anymore. Now, FISA asked me to cover occupational post-exposure prophylaxis because this is a concern. If you are going to provide HIV care, you have to take care of your own health and you have to prevent yourself from getting HIV. So I will do a short presentation on occupational post-exposure prophylaxis. There is so much myth, so much misinformation, so much stigma, and so much fear from healthcare providers about HIV transmission. The honest truth is splashes with body fluids on intact skin is nearly zero transmission if there is no blood in any of these fluids. Fluid splashes on intact skin or even mucous membranes, your nose, your eyes, is extremely low risk even if blood is involved, okay? What we really are worried about is percutaneous needle stick injury. But even this is less than 1%. Less than 1%, the actual number is 0.33%. So it's extremely low. Even if your patient is HIV positive, use the needle, you got the needle stick. It's extremely low. And yet, we are so worried about getting HIV. Our real risk is low. What we should worry more about is hepatitis B and hepatitis C transmission, which are so much more transmissible. Of course, there's a difference, right? Hepatitis B has treatment, and now hepatitis C has a cure. HIV still has no cure. We have vaccines against hepatitis B, so all healthcare providers should be vaccinated against hepatitis B to prevent them from getting hepatitis B. We have no vaccine against hepatitis C, but we have a cure for hepatitis C. So I know that we should worry more about hepatitis B and C, but I also understand that we can do something about hepatitis B and hepatitis C, but we cannot do anything about HIV because you're our vaccine. But universal precautions help. Just treat all your patients as if every one of them have HIV. Use gloves or goggles and other barriers when you are anticipating contact with blood or fluids. Immediately wash hands and skin surfaces after contact with blood or body fluids. Be careful when handling and disposing sharp instruments during and after use. Use safety devices to prevent needle stick injuries, which we have here in the US, but my experience globally is you don't have it, so be very careful. Dispose of syringes and other sharp objects in a sharp container, which means that it should not be it should be a puncture-proof container. And then if for one reason or another you get a high-risk exposure, which means the patient is HIV positive, unknown status, has risk factors for HIV, you had a percutaneous injury that included blood, again, Dolutegravir is the go-to medication in conjunction with 2 nucleoside reverse transcriptase inhibitors, which would be your Truvada, okay? Or you can use Dolutegravir if it's available, or boosted Darunavir, which we almost don't use anymore. If we have Dolutegravir, that is what we are going to use. You need to take this for 4 weeks, and you need to be monitored. So blood work has to be done at the time of exposure for HIV, hepatitis B, hepatitis C, your kidney function, your liver function, your CBC. Those are minimum that needs to be done. You go on post-exposure prophylaxis at 4 to 6 weeks. We repeat your testing for HIV and again for hepatitis C.
If you are immune to hepatitis B, there is no reason to test you again for hepatitis B. Then we need to monitor your blood work again to make sure. So follow-up testing is 6, 12 weeks, and 6 months post-exposure. I think that I'm going to end my presentation there. I just want a summary to remember we can eliminate HIV mother-to-child transmission with combination antiretroviral therapy. Continued combination antiretroviral therapy can prevent breastfeeding transmissions. Occupational HIV transmission can be prevented, and it is of low percentage. We know the science. We need the will and the resources to implement all of this to prevent mother-to-child transmission. Thank you very much, and I'm happy to entertain any questions.
Thank you so much, Dr. Susan Cu-Uvin. This was extremely informative session for all of us. I greatly appreciate it. So as for our question and answers, we would like to do it towards the
At the
of
end?
the talk.
Yeah,
Yes.
sure.
Thank you. I
Thank you.
appreciate it. So I would now like to introduce our two panelists, Dr. Fatma Mir and Dr. Aisha Ilyas. So I'll start with Dr. Fatma Mir. Dr. Fatma Mir is an associate professor, Department of Pediatrics and Child Health, Aga Khan University Hospital, Karachi, Pakistan. Dr. Mir completed her medical education from Khyber Medical College, Peshawar, and her fellowship in pediatric infectious diseases from the Aga Khan University. Her research interests include neonatal infections and pediatric HIV. Dr. Mir will talk about HIV during and after pregnancy and options for treatment in Pakistan. So before I hand over to Dr. Fatma Mir, I will go ahead and introduce our panelist, Dr. Aisha Ilyas as well. Dr. Aisha Ilyas, MD, she's working as consultant infectious diseases, Aga Khan University Hospital, Karachi. She is also consultant infectious diseases and infection control, Taba Kidney Center, Karachi, Pakistan. Dr. Ilyas is graduate of Dow Medical University and completed her fellowship in infectious disease from Aga Khan University, Karachi, Pakistan. Dr. Ilyas will talk about safety, precautions for healthcare workers assisting with delivery process to avoid HIV transmission during delivery. So I will now welcome Dr. Fatma Mir to go ahead and give her talk.
Thank you very much. And I'm honored by your invite to be a panelist. Professor Susan actually touched on almost all the relevant points. I have to give you a Pakistani perspective, and that is that regardless of HIV, Pakistan is one of the countries with very poor maternal mortality statistics. So regardless of HIV, 59 women die out of 1,000 who are pregnant in Pakistan. And this basically means that MNCH, or maternal and child health services, are really poor. Now, there is evidence, like Dr. Susan said, we have the science, we know what to do. So high-income countries generally will have better pregnancy outcomes in most patients who are in vertical programs, such as TB, such as HIV. And the same goes for Pakistan also. Women who are pregnant and we find out they are pregnant during, we find out they're HIV positive while they are pregnant, they are very well taken care of by the HIV provincial control programs and by the national HIV control program. Our bottleneck is testing enough pregnant women to have a true proportion of what our vertical transmission in Pakistan is. And the reason for this is most of my colleagues who are right now attending this session, you all know that our home births are much, much more than facility births. And this is true, well, it differs from province to province. Of course, home births are highest for Balochistan, lowest for Sindh. Similarly, high for rural, low for urban places. But the more chances you have of having home births, the more chances there are that traditional birth attendants are attending the birth, which means there's poor ANC and there is poor capture of that pregnant woman and her Hep B, her Hep C status, her HIV status, her syphilis status. Now, post Larkana 2019, the one thing which the Sindh government has, I won't say implemented, but at least has shown commitment to is universal testing for HIV, Hep B, Hep C, and VDRL in Sindh. And maybe the next 2 years will tell us how that is implemented. I want to reiterate what Professor Susan pointed out, and that was, how do we capture enough pregnant women to be able to generate a true statistic for how much HIV we have in our pregnant women? And one way which we have been discussing now among the HIV circles is maybe by involving and recruiting traditional birth attendants and giving them a point of care test, which is easy to do, so that those women can be tested at the time of birth or during ANC and sent and referred early in pregnancy. So that's one thing which is being discussed. The second is health education. We have a very high health illiteracy in the country, and there's very poor awareness among the community about how important it is to be tested and to have a supervised pregnancy. So maybe these are things which have to be taken up also. I have been looking at MTCT outcomes in the HIV positive pregnant women cohort in Larkana, and we have good birth outcomes in all the women who were enrolled in the PTCT program in Larkana. It just gives you an idea that the more supervised you are, which you generally are if you are enrolled in any vertical program, whether it's TB or whether it's HIV, you have more encounter with healthcare professionals and you end up being better taken care of. And we have been trying to get statistics of the non-HIV pregnant women, and there's very poor data on them because they're almost empty registers. So we can't tell you how, we can't compare the non-HIV outcomes, pregnancy outcomes with the HIV outcomes. We feel that it's better in the people who are taken care of. So these are all the real problems on the ground. And this is how the textbook and the science differs from what is being implemented in the ground. Aisha, do you have anything to add to this?
Dr. Aisha, we can't hear you. Yeah. Dr. Aisha,
I think you've hit the core, Dr. Fatma, that health illiteracy is the core problem for high maternal mortality in Pakistan. And if we could address that, and I really appreciate the fact that point of care testing should be mandatory, especially in high prevalence towns of the country. And that would probably look after a holistic approach of taking care of not only the pregnant females, but also their families. And this will lead to much more elaborate diagnostics within the community.
So the conversation which the National AIDS Control Program is having with HIV academicians across the country are, how do we increase the testing net? This is our bottleneck, and we are very aware of it. And I think it needs for government people, first line healthcare professionals, and then people like us at tertiary care to sit together and see what can be done. And it will involve compromise, because I don't think a country like Pakistan has the money for the ideal, which is house-to-house testing and aggressive resource allocation to this. But it has to be a combination of involving the community, involving the health cadre, and then doing smart testing, which means maybe, something like index link testing, find out where the positive cases are, adults and children, and then do sort of testing around that area, because that's a place where transmission is going on. Okay. So these are all things which are being discussed.
So Dr. Fatma, how does the lady health worker applies now? It was a very popular program. I think it really takes care of much of the primary healthcare within the rural areas. Yes. So is it still functional?
The lady health worker program has a MNCH mandate, and it began as family planning, midwifery, and postnatal care. But the polio program and the polio NIDs and SNIDs
Seems to be a bit of technical issue. Dr. Fatma-Mir, we lost your audio.
Okay, maybe I can pitch in. The
Please.
lady health worker program is overburdened because we have a limited workforce of women who go out in the field with, and their primary responsibility is their MNCH program. Any outbreak or any problem which develops, the additional work is handed over to lady health workers. So in the current grant application, we were actually very careful in not overburdening them with more work. So we need to define our workforce and redefine the kind of duties we can assign them, and actually work towards increasing the workforce if we really want to utilize them for community-based work. Secondly, regarding screening of pregnant women, there has been no effort in integrating delivery of healthcare amongst the different programs we have. So HIV is working separately, TB is working separately, hepatitis C virus program is working separately. So with the current grant, and we've had a recent opportunity of applying for a COVID mitigation grant, which is again being funded by Global Fund. It's a C19 RM grant, and we've had the opportunity of trying to integrate the clinical care involving TB, HIV, malaria, and we are even talking to hepatitis C program, just to have good, robust healthcare facilities where we can provide the one-stop shop concept. So a person can come in, get tested, screened, treatment would be provided, and all the diagnostics, essential basic diagnostics would be available. So we are working towards achieving this kind of clinical care provision.
Thank you so much. I would like to thank Dr. Fatma-Mir for her insight into challenges in Pakistan. Very informative. So now I will hand over to Dr. Aisha Elias for her talk. So all yours, Dr. Aisha.
All right, let me share my screen.
Sorry, guys, I lost you for a while, but I think you all covered it.
Actually, Dr. Bushra pitched in for you.
Thank you, Dr. Bushra.
Yeah,
thank you.
Good to have you back.
All right, so most of the things that I will be covering in this talk have already been covered by Dr. Suzanne. So I'll just quickly go through the major things and major hurdles or the bottlenecks, as Dr. Fatma-Mir points out at our end. So safety precautions for healthcare worker to avoid HIV transmission, and this is in respect to obstetrical care. So the problem, the content is pretty simple. We look at the problem, the root cause, and possible solutions to explore. So according to WHO, 3 million healthcare workers are exposed to blood-borne viruses each year, and 90% of the exposures occur in the developing countries. Developing countries are also at a higher risk of seroconversion to blood-borne viruses and after the exposure, as opposed to high-income countries where seroconversion to blood-borne viruses close to zero. So, and these are the two contrasting studies, one done in Cameroon with a high prevalence rate of HIV in the normal population, and the other one from US Pittsburgh. And it really shows the inequality between the two continents. The places which have a higher disease burden, the healthcare, the incidence of HIV amongst healthcare worker is close to 3%, as opposed to a highly developed country where the seroconversion is virtually zero. So if you are a healthcare worker belonging to a poor income country, then you have more chances of acquiring blood-borne viruses during your practice. So essential, the basics of what exposes the healthcare worker to HIV, and we all know that contact of body fluids, especially blood, rectal and vaginal fluids with the mucous membrane, or injected directly into the bloodstream. But more importantly, lack of training in safe infection control practices is really the core issue here. Despite of all these unhealthy practices and unsafe practices, the risk of HIV transmission is only 3.3% for percutaneous route, and cutaneous is 0.09. It is fairly low when compared to other blood-borne viruses like HIV, like hepatitis B and hepatitis C. So the core and fundamentals of safe infection control practices is the standard precautions. The core elements of standard precaution points for the fundamentals of the fundamental elements of infection control or safe infection control practices are hand hygiene, use of appropriate protective gears, gloves, and other gears when needed, safe injection practices, proper disposal of sharps, proper disposal of medical waste, uh, environmental cleaning, and safe handling of dirty laundry. These are the basics and core of infection control, which should be implemented and should be routinely practiced by all healthcare workers. For healthcare worker to prevent the exposure to blood and body fluid or HIV, they need to assume that all blood and body fluid exposures are likely to be infectious. And so appropriate gears and infection control practices should be adopted for each and every opportunity where there is a risk of exposure. So as Dr. Susan pointed out, over the years also, the prevention remains the cornerstone in the management of HIV. So, and we could minimize the exposure to blood and body fluid, which is essentially the core reason of acquiring these bloodborne viruses, by safe disposal of sharps, by practicing proper waste management, by safe handling of laundry, by proper environmental cleaning, by cleaning of the sharps and instruments that need to be reused and disinfected and sterilized. So these are the core problems, these are the core practices that should be adopted by each and every one to prevent exposure to blood and body fluids. During an obstetrical care, the exposures are either antenatal, during intrapartum or antepartum, and postnatal. All these cares expose the healthcare worker to blood and body fluid exposure. So for example, during antenatal care, using disposable linen or disposable swabs or disposable instruments will minimize the risk of contamination. Covering the ultrasound probes with a barrier and then cleaning them afterwards will decrease the further and cleaning the probe will further minimize the risk of transmission. During phlebotomy is one of needle stick injury is one of the major concerns during healthcare workers for exposure to blood. Safe disposal, do not recap, and by not recapping the needles, and safe disposal into puncture-proof bins is the way to prevent them. Then antepartum is the most high-risk exposure area. During this during antepartum care, nursing care, IV cannulation, medications, surfaces of delivery room, rupture of membranes, delivery of the child and placenta, and use of sharp instruments or delivery instruments really exposes the healthcare worker to all those risks. To minimize the risk, again, all we have to do is to follow the standard precautions. Again, postnatal, which poses a much lower risk of exposure, but again, needle stick injury and IV medication and cannulation exposes to percutaneous risk of healthcare worker. So up till now, the exposure can be minimized by prevention, and this is the cornerstone of HIV management. But even after the exposure, the occupational health and the post-exposure prophylaxis should be advocated. So the staff should be aware, all the healthcare workers should be aware that all the needle stick injuries and sharp injuries need to be reported promptly. The staff turning up at the occupational health are mostly worried and afraid, and they need to be counseled properly. They need to have their baseline investigations, and usually we initiate ARV right at the clinic as early as possible. In Pakistan, we are using a combination of 3 antiretroviral as a post-exposure prophylaxis for 28 days, and we follow them at 6 weeks, 12 weeks, and 6 months with ELISA. One important thing that Dr. Susanna also pointed out, that counseling for avoiding pregnancy and blood transfusion and surgical procedures that may expose others to the risk of their blood and body fluid transfusion should be avoided. So to summarize all of this, you can protect yourself by using proper use of PPE, safe infection control practices as mandated in the standard precautions, and report every exposure early. Unit responsibility is to ensure the availability of gears, materials, disinfectants, and chemicals that are needed to ensure infection control practices. And education, awareness, audits, and reinforcement of the infection control practices is very important. The most important task is the administrative. The administration has to take the lead in infection control practices. So all healthcare workers should be trained for infection control practices at the induction and periodically. All institutions should develop written policies so there is no ambiguity at the time of exposure. They should ensure availability of materials and gears and adopt engineering controls to minimize the risk of needle stick injuries. So the core responsibility of infection control lies in the administration of the hospital. And infection control is not anyone's else's responsibility. It is everyone's responsibility. And prevention is the only cornerstone by which we can avoid to get HIV. Yeah, that should be it.
Thank you so much, Dr. Aisha. Extremely important topic on safety and prevention of HIV in healthcare worker. So it was extremely informative for all of us. Do you have more slides, Dr. Aisha?
No, I'm actually done.
Okay, all right, okay, thank you. Yeah, just want to double check on that. Now we will proceed to question and answer session. So I will go by one question at a time. And let me pull up. So we have a question from Dr. Sardar Shah. And his question is, how long can you live with HIV without knowing? So I will have Dr. Susan Cu-Uvin, if you would kindly would like to answer that.
Susan, you had to unmute yourself.
I'm sorry. The problem with HIV is you can have it, but you can remain asymptomatic for a long, long time, as long as 10 years before you really get very sick and before you exhibit opportunistic infections that are suspect for having HIV. So although we have what we call the fast progressors, that within 3 years, they are very sick, they are rare. And then we also have the slow progressors who go beyond 10 years, 15 years without any signs of HIV infection, even if they have HIV infection. But most of the time, by 8 to 10 years, you are going to show signs and symptoms of HIV if you have not been diagnosed.
Thank you very much. So I also would like to add one more panelist to our question and answer session. That's Dr. Faika Chugtai. She's practicing gynecologist in CMH. She's with Military Hospital, and she has practiced over 25 years. So extremely skilled and a lot of experience in treating pregnant women in Pakistan. So Waleed, if you can kindly add Dr. Faika to our panelists. Thank you. Thank you for joining, Dr. Faika. We highly appreciate it. So I have a couple of questions, which actually there are multiple questions. And I would like Dr. Faika, I would like to hear from her, given her extensive experience in Pakistan. So Dr. Saima Abbas, as well as Dr. Amjad, they have kind of similar questions. So their concern is about implementing universal HIV screening in pregnant women, given stigma in Pakistan. So their question is, what challenges is to be anticipated, given that can have a very negative outcome on the family, raising the questions about domestic violence as well. So Dr. Faika, if you would kindly like to answer that for us, please. I'm not sure if Dr. Faika can hear us. If Dr. Aisha or Dr. Fatma Mir, would you like to kindly answer, or Dr. Susan Cu-Uvin? I know Dr. Susan Cu-Uvin has a lot of experience in underdeveloped countries as well.
Well, I'd like to give Dr. Aisha and Dr. Fatima the first chance to answer,
Sure.
because this
Sure.
is
Right.
about
Sorry.
Pakistan. I'm happy
think-
to help.
So I think I'll leave the adults to Aisha, but I think quite a few of people in Q&A have also mentioned their concerns about stigma. And the truth is that in a real life scenario in a public sector hospital where OPDs have up to 4 people being seen together in the same room with 2 to 3 physicians, confidentiality is almost impossible to implement. And second thing is that it's a combination of poor knowledge and then a complete lack of infection prevention and control in a hospital, poor knowledge of where a physician will go if they do get a needle stick injury. And all these things compounded create anxiety in a physician. So you are very, very right. You have a lot of OBG physicians. We have patients who will come all the way from small cities to 700 kilometers, say, to Karachi, because the physician, the surgeon, the obstetrician has refused to touch them.
Hello.
This basically means that systematically, so this means that systematically we have to deal with physician education, physician training, lack of knowledge and lack of logistics to create a safe and clean environment in the health facility. So there are solutions. It just needs commitment from individual health facilities and from the policymakers at the government level. No implementation, especially in low-income countries, is possible without continuous monitoring and feedback. And this is where we lack.
Hello.
I think Dr. Faika
can you all hear me?
Joining. Yep. Dr. Faika, if you can kindly put yourself on mute. Dr. Fatma, please carry on answering the question. Thank you.
So, I mean, yeah, Faika, please feel free to join in. But Safana, what I want to say is that we are very aware of the weaknesses. This HIV outbreak in Larkana in 2019 was not because of one person. It was because of a complete breakdown at every level of healthcare. There was more than one chink in the armor. And the truth is that no matter where we went trying to look at the causes which could have led to the outbreak, we found almost everything lacking. Knowledge of the physician, any kind of health literacy in the end user, who is the patient, no concept of infection control. Those who had a concept of infection control had nothing to practice it with. There was no clear reporting, a reporting pathway that if somebody does have an injury, who do they go to, who do they report to? And this is while you have a functioning provincial AIDS control program in the country. So the place where the vertical program meets general public, general health is where we lack the coordination among vertical programs to create laterality. This is what the government is trying to do now. But again, if there is no regular check, there's no regular accountability. What we know, as Dr. Susan said, we know the science, it's implementation science which lacks. And this is what we as physicians and people who are interested in HIV need to make sure happens over the next 5 years. And now with Dr. Bushra in an important administrative post in Islamabad, now we have an infectious disease brain sitting in Islamabad. So we feel that now maybe the physician talks to the policymaker, talks to the government, talks to the end user, that loop can maybe be more productive in the coming few years. Aisha, anything else you want to add?
No, Dr. Fatma, you have really covered it well. I think the health illiteracy and lack of knowledge, and so infection control practices are unknown by far. The practices are have improved a little in the urban Sindh because of the initiatives taken by the Sindh Health Commission, but the rural areas still are untouched. And essentially, as Dr. Fatma pointed out, they don't, I mean, if you would meet a physician, a family physician, or a general practitioner in not even in a rural Larkana. Larkana is not a rural city, but in a small town, you would find they're like they don't know what are the basic practices of how to manage what to do with a needle prick if they are pricked. They don't even know how to dispose them properly. They are just using used syringes from one patient to another, and these are certified and qualified MBBS physicians. So lack of knowledge and lack of awareness and dissemination and poor dissemination of information are the core issues that we are battling with. And this is not true only for the rural areas. This is uniformly applicable to small towns. Karachi being a bigger city and an urban city, it's probably better off. But throughout the country, small towns suffer. And up till now, I don't see much of an initiative, except for after the Larkana outbreak, to improve this.
I think I also want to tell you all that I think Aisha is the secretary and Dr. Bushra is the president of the Medical Microbiology and Infectious Disease Society of Pakistan. This is basically a group of infectious disease people who are coming together and who are now very, very cognizant of the poor infection control across Pakistan. And I think we are very, very aware that you have to realize that the lack of training is not, it's happened over time. There are a lot of unregistered, poorly supervised medical colleges in Pakistan. You have medical graduates coming out who may or may not meet the mark. Not just infection control is beside the point. You have very, very capable physicians who have poor infection control training just because they haven't been exposed to practicing it in their daily practice. And I know of an example in which an FCPS pass pediatrician saw a safety a safety box in which those injections are disposed of for the first time when they visited AKU after the FCPS. So because they trained all their lives in a public sector hospital and never saw one. So there are these kind of gaps which we are dealing with post facto, and they need to be addressed at undergrad training, graduate training, post-grad training, nursing schools, physiotherapy schools, dispenser and ancillary service schools. So they need to be practiced in various places. And as Aisha mentioned, the Sindh Health Commission, no matter how many quacks it shuts down, they will mushroom again after a while. And the reason for that is supply and demand. If the community keeps begging for injections, they will find somebody, even somebody, walking down the road who will be ready to give them an injection for 30 rupees. So this is the kind of, somebody wrote jihad, and yes, it's a jihad, and it has to come from social sciences, medical cadre, academicians, community workers. The one thing the HIV program lacks is community peer groups. And that's what people like the Bridge Foundation are working on in Pakistan. So we are hoping now that the different silos of people working for HIV and in HIV and with HIV in Pakistan come together now and sit together at the same table again and again and again, because the battle of addressing IPC is going to take at least a decade. It's not a short fix. It's not a short, it won't happen in a year or two. There are going to be no quick dividends. It has to be slow and systematic and steady. So we are hoping all of you are going to join us in this battle. Dr. Susan, I think we should invite you to Pakistan because your talk was fantastic and I think it covered all ends of the conversation.
Well, thank you very much. That's very kind. Fisa will tell you I travel all over the world and I would love to. It's the first time in 30 years that I have not been out of the country because of the pandemic, but I do work in Bangladesh. I do work in, everywhere. And I would be honored to come to Pakistan. And remember, there was a plan before the pandemic to bring
you to Brown and host you. And we were looking forward to hosting all of you, but the pandemic has changed all our plans. But I do hope in the future that our collaboration can continue and grow, and that we will find a way eventually not to meet in person and not just virtually.
Dr.
Thank you.
Fatma Mir,
Fantastic.
thank you, Dr. Fatma. Thank you very much for this very comprehensive analysis. And that is the main reason we created this platform. So let's start talking about these issues. Thank you.
I think Fiza and Safana, thank you, because all these sessions create a community which can then spread the word. So Aisha, myself, Dr. Bushra, I think we all say thank you. This is fantastic.
Yeah, excellent. That's the goal here. So I would like to include Dr. Faika to answer, some of our questions.
Yes, please.
And I greatly appreciate both Dr. Fatma, Dr. Aisha on their input on the challenges in Pakistan. So Dr. Faika, I have a couple of questions for you. You being a practicing gynecologist in Pakistan, what is your thoughts on universal testing for HIV, and what challenges do you anticipate? And also, there were a couple of questions about backlash on healthcare workers. You as gynecologists, do you face that in your practice when you bring up? Walaikum assalam.
Can you hear me?
Yes, we can hear you, Dr. Faika.
Okay. Thank you for inviting me for some comments. As a part of the Army healthcare services, we don't do HIV screening wholly. We do the HIV screening along with hepatitis B and C in the province of Sindh, and not the other parts of the country. So the load of HIV infection in this specific catchment population, which the army hospitals are dealing with, that is not actually known. Probably this is the thing with all the civil sector also. Rest the province of Sindh. In Sindh, as in Hyderabad, I have seen 3 women giving birth with HIV infection. 2 of those women were with the active disease, and all the protocol of natal treatment was given, antiviral and antiretroviral treatment to the 2 of the women were given. One was disclosed this thing and was positive after birth. The load of HIV infection in army hospitals is comparatively low as compared to the other viral infections like hepatitis C and hepatitis B. The one thing is good in this area is that all the treatment is easily available and free of cost. So if the screening is done, it is comparatively easy to manage the cases till the completion of the treatment. There is no burden on the economy of the pocket of the patient or the system as such. The other, can you? There is generally in province of Sindh, as I have seen for the last 2 years, the ill health, the emaciation, and low nutritional status is probably more than the rest of the country. Dr. Fiza, the Aga Khan hospital is a better place to throw some light or analysis on this part of the health issues. But generally, the women of this area seem to be ill-nourished and lean, thin, with low BMIs. So probably the defense mechanism and immunity is all the things are low. Can you ask a question from if Dr. Susan can come to Aga Khan Hospital in future, and do some combined work guiding the people on this viral transmissions and the treatment and so forth, we will be more than happy and will join her in this thing.
Thank you, Dr. Faika. Thank you. I appreciate it. And Dr. Susan, you really will have to make a couple of trips.
I would be happy to come, and thank you so much for your warm invitation. Unfortunately, I have another Zoom call, so
Okay.
I have to leave, but I did put in the chat that any questions you have for me, if you send them to me by email, I will be happy to answer them all. Because I cannot travel, you know, I have to do work for Kenya, Uganda, Philippines, Bangladesh, and they're all, you know, they all mesh sometimes. I cannot control my schedule. So my sincerest apologies, but thank you so much for your warm welcome. And I would love to come to Pakistan. Teresa knows that.
Thank you so much, Dr. Susan.
Thank you. Thank you so much.
I understand you have another Zoom call.
Yes, it's
okay.
too much, you know. Yes, they pile it up on the weekends.
That's what happens.
Last night I had from 11 p.m. to 1 a.m. here.
Wow.
And sometimes it's 2:30 a.m. But it is what it is with the pandemic. Thank you so much.
Thank you so much. Appreciate it greatly. So I have a couple of more questions, and there is a question about by Dr. Syed Hussain about availability of rapid HIV testing in basic healthcare centers in Pakistan and women care centers. So any of the panelists, if you...
Yeah, I think Safana, I've sort of tried to answer this. BHUs in Pakistan are in the thousands. Now, the machine which runs the point of care HIV test requires specific conditions. It can run a limited amount of cartridges a day, and it requires a lab technician to be there to run the machine. In Pakistan, still, prevalence of HIV in the general population is not high enough to warrant that kind of cost, the cost of running those machines. So even though we are saying we want universal testing for pregnant women, running those machines in any center which takes care of pregnant women may not be a cost-effective solution. The aim is to have a safe, stigma-free, smooth referral system in which the pregnant woman can be sent on X number of days, on X day, X time to a certain center where the testing can take place. So yes, it is ideal to have a point of care test available at any healthcare facility which takes care of pregnant women or any person who is suspected of HIV, but this is not our reality. Our reality is to smartly refer people at the right time to the right place.
Thank you.
I would like to comment here, because we have, we have the cheaper point of care testing kits available as well. So it's a two-step strategy, and these are actually kind of immunochromatogen type of testing. So which is not very reliable, but still good enough to be used as screening test. And these are being supplied to the TB centers as well, because we
fantastic.
The one step which has been taken is making HIV screening mandatory for any newly diagnosed TB patient. So that is one step, and those kind of kits can be made available at other healthcare facilities. But again, the challenge here is not to identify a center as an HIV center. It should be a general kind of a healthcare facility, providing care to everyone, and without anyone being identified as having TB or HIV or any particular infection. So that is the challenge, and we are working towards it. We are very cognizant of this fact.
Mm-hmm. Very good point, Dr. Bushra. I think labeling it as HIV or TB, that just, the stigma gets, deeper and deeper. Yeah. So I have another question. I love this question. So this is a question about if there is a mosquito bite to HIV infected person, and then he bites another person, can HIV be transmitted that way?
This is Dr. Bushra's question.
Yes.
Arzu
I think I
knows this
responded.
person. Yeah.
Yeah. I haven't come across any case report of HIV being transmitted by a blood-sucking insect, be it a bed bug or a mosquito.
Okay.
So I haven't come across it. Yes.
I think it is very
So very interestingly, the question which I get as a pediatrician is about children who bite each other in the playground. And this is the same answer which I give to them.
Yeah, excellent. All right. And Dr. Aisha, you wanted to say something?
Yeah, I think it's getting on this forum. It's an opportunity to address a few issues, and Dr. Bushra and the team in Islamabad, I think, really making progress. But Dr. Bushra, one of the core issues, we have to work really hard on creating awareness and disseminating the correct practices, and this is one of the, I think, most neglected areas, because it is, as Fatma said, it is not going to be a quick fix, but this is the only fix in the long run that would be most beneficial for it.
Yes. I would divert this comment to Dr. Fiza Gilani, because she knows how much time and effort has gone into making this possible. And this is just the first step. Dr. Fiza?
Yeah, thank you, Dr. Bushra. Yes, and this is our it's a great partnership, and I hope you all will continue this partnership in future. And we created this series of webinar. It means we have to get all these actually presenters. Our aim was to present the science through USA faculties, and then getting the best practices from USA and best practices from Pakistan. And our next steps are we will create a report out of these webinars and combine all these different suggestions and policies. And we will publish it on different platforms. You all will get a copy of that. Next step will be we will create a HIV 101 course, which will be allowed to get CMEs. And we will encourage all those physicians working in remote areas, and it can be anyone, nurses, physician, non-HIV physicians, they can take the course. And then we'll continue our partnership with all of you guys. There are a few more course like projects in line. We will give the details of them at the end, like end of this project actually, because we are doing this one in 3 different parts. And thank you, Dr. Bushajmil, for all of your help in this.
You're most welcome. Thank you.
Okay, so there is another question posted by Dr. Naveed Khan that is for Dr. Bushra. And Dr. Naveed's question is, how long can you live with HIV?
I think this has been answered. Again, the same thing. If untreated, then around 10 years or so. But if on treatment, the lifespan is the same as that of an uninfected individual.
Thank you. Thank you, Dr. Bushra. So there is one more question. Dr. Saima Abbas, among her several questions, one of the question was, what if a healthcare worker, they decline to see a patient who is HIV positive? She's fearing here backlash on the healthcare provider to bring up the issue of HIV and treatment and domestic abuse, and then healthcare workers, getting sucked into the whole situation.
Again, it's our responsibility as physicians to make people understand that this is an infection. And especially in our context, it has spilled over into general population. So key populations aside, it is the general population which is suffering, and we have the same problem with HCV. So just making everyone understand that this is an infection. It can be acquired through many different means. Making our healthcare workers and doctors more aware of what to do, how to handle it, how to manage it. And I think one important step which we have taken through this webinar series is engaging family physicians, because they are the ones who should be able to offer treatment at the basic health units. So making everyone aware that this is an infection, what to do. There are simple steps for screening, for offering treatment, so on and so forth, and maybe basic steps of counseling. Just take the stress and the blame game out of the entire discussion. Treat it as any regular infection, and just follow the simple steps which are required for management and for ensuring compliance.
Thank you, Dr. Busha. Yeah, go ahead, Dr. Faiz.
I'm sorry. This should be better tolerated and better dealt in the era of the pandemic of this COVID-19. If this is more lethal virus, and it is so much lethal that lakhs of the population has been died. So it is the HIV is comparatively innocent then. If healthcare workers are dealing with the COVID patients, they should be better dealing with HIV probably.
Absolutely. Yes, I agree. Yes. Thank you.
It's a valid point.
Dr. Fiza, there is a couple more questions. So I will post this question, and I believe it has been answered, but I would like to repost it here on the forum. So the question is, if one partner is HIV positive and other is not, and they are planning to conceive, so how long should they wait, and what should be the ideal viral load before they can try conceiving?
So the aim is to have an undetectable viral load, and the treatment can be offered to the partner as well. So we have serodiscordant couples where both the partners are on antiretroviral therapy. And the additional step which is recommended for just to avoid the woman being infected if the husband is the infected partner during pregnancy or during trying to conceive, is to have the semen washed, so sperm washing, and then in vitro fertilization. And that just takes away all the risk of infection spreading from husband to wife. So antiretroviral therapy for both the partners, and then sperm washing and in vitro fertilization.
Thank you. Thank you so much. Okay.
Safana, there is a question by Dr. Sardar Shah. He's asking, can HIV live outside the body?
Yes, yeah.
In our very first webinar, we had a question that was for everyone, that how long HIV virus can survive in a syringe in a room temperature, on a room temperature. And we asked it everyone, and the answer is 42 days. So it means HIV virus can definitely live outside the human body. It can live in the tube or syringe for 42 days on a room temperature. So now just think about reusing that syringe. If someone is reusing that syringe again and again during those 42 days, we can think the consequences. And other question is from same participant. It is a lot of efforts are being made only in theories and not in practical. So I think this project with everyone's help and everyone's collaboration is a practical solution, and we should continue this. And you all at your own level should continue these kind of efforts. Thank you.
Thank you, Dr. Fiza. So I have one more question posted on our Q&A section regarding disinfection of ORs, in Pakistan, that how effectively it's done. A question has been posed that if somebody comes in, for example, with leaking aneurysm, and they know there is HIV positivity, then surgeons are, healthcare providers are reluctant to touch the patient.
Yes, that is a very real issue, and we are trying to address this again by following this model of one-stop shop. And we are actually in the process of identifying those healthcare facilities which are located within or close to the hotspots of HIV. We will engage all the physicians, surgeons, make them undergo training with us. So engagement, signing of MOU, and then facilitating patient care so that HIV positive patients don't have to run from hospital to hospital to get treatment. So this is a very real issue and has to be addressed. And it is, in my mind, at least all the time. This has to be addressed.
Agreed. And I think, I mean, there are people who are refused a cataract surgery, which is a bloodless surgery. So even bloodless surgeries, people are refusing them. Dr. Bushra is very, very right. And we are usually, when we go to hospitals, they will say, oh, we have a Hep C OR, but we need a separate Hep B OR, and now we need a HIV OR also. And the reason is just a complete lack of, they don't know how to do terminal cleaning, and they have no concept of doing it even for HIV negative, Hep B, Hep C negative people. So infection control, the lack of infection control is why people say, and they have beautiful incinerators lying over there, but they may not have the fuel to run it, or they don't know how to run it, or it's just too much hassle to do it. So I'm very glad that this is being addressed now. But as Dr. Bushra said, this is a work in progress, and it's going to require commitment and consistent commitment. And I hope, inshallah, that it'll come to happen, inshallah.
Inshallah. So any comments from any of our panelists, Dr. Fatma, Aisha, Bushra, Dr. Paika?
So I would like to say a few things, Aisha. Sorry, Safana.
Yeah, please go ahead.
So take home for all these people, and especially if there are family physicians listening to us, HIV is just a stigma, and a stigma of perception. The facts are that the transmission incidence of transmission is fairly low for HIV as opposed to hepatitis B and hepatitis C. You don't have to take any special measures in cleaning the ORs after operating on an HIV patient. The standards of terminal cleaning for HIV, non-HIV, Hep B, Hep C stay the same. Standard precautions is the core of preventing HIV infection transmission in a healthcare setting. And these are some basic practices of infection control that needs to be adopted and practiced routinely. There is no special science or technique by which we can reinforce or eliminate the chances of eliminate the prevention or eliminate the chances of exposure. We just have to be mindful, as Dr. Bushra said, this is infection like any other infection. The basic infection control stays the same across the board for all blood-borne viruses, and especially for HIV, the transmission incidence is very low.
Thank you, Dr. Aisha.
I think from my point of view, it's very difficult to nurture kindness in people, and as a nation, maybe we have trauma fatigue or disaster fatigue. We are apathetic, just the baseline psyche of most of us. So we are unkind. We are unkind to people who are unwell in our families. We are unkind to people in our workplace. We are unkind to people who are the end user of our services. And I come from a specialty where even if a child has asthma, he is stigmatized in the family. So Hep B, Hep C, HIV, is another bala. People think God knows what it is. And as Aisha said, and as Dr. Bushra said, it's just an infection, and it is treatable, and it is very difficult to spread it from one person to the other. I mean, things have to be lacking at a lot of levels for it to spread from one person to the other. And I think if we, like most things, if we educate ourselves and educate the end user and create a stigma-free and a non-judgmental health facility visit for the person who's coming to visit us, it will generally lead to better uptake of what we have to say.
Thank you, Dr. Fatma-Mir. Absolutely. Kindness, touch of kindness it can change so many things. And it is certainly lacking, sadly. Dr. Fiza, would you like to add any comments before we close? Or Dr. Bushra?
Oh, thank you. I think everyone has participated very well, and very good points are raised today. And this was our main purpose doing this. And just to add a note, in a few minutes, everyone will get the email for the evaluation form. Please do it. We need that for our report and for our continuation. Thank you very much.
Thank you, everyone. It was very well attended. We had about 90 participants, and great discussion by all our panelists. Greatly appreciate Dr. Susan Coven, Dr. Bushra Jamil, Dr. Aisha Ilyas, Dr. Fatma Mir, and Dr. Faika Chaptai. And special thanks to Dr. Fiza. She's been a champion of these webinars and other educational activities. And thank you to APPNA-MERIT as well. Thank you to all.
I could not have done this without you, and especially all APNI board members who were our moderators. Thank you very much. And again, everyone's participation was very, very important for us. Thank you very much.
Thank you to all our members, all our attendees as well. Thank you so much, everyone.
Thank you.
Allah Hafiz. Khuda Hafiz.
Khuda Hafiz, everyone.
Thank you. Khuda Hafiz.